Ms Harris, good morning.
Good morning, Chair. Chair, this morning we turn to the inquiry's examination of potential systemic issues in relation to emergency response and resuscitation. We will begin with an update on the inquiry's investigation of this topic, and then we will hear from Mr. Adam Benson-Clark, who will be giving evidence on behalf of Resuscitation Council UK. Mr. Benson-Clark will be giving evidence of the standards to be expected in relation to emergency response and resuscitation on mental health inpatient units. He will also be giving evidence about cardiac arrest and about the clinical issues relating to medical emergencies on mental health inpatient wards. This afternoon, we will hear the recorded evidence of Beverly Switzer, who is a member of staff at EPUT. She provided her evidence during a recorded evidence session last Friday, having been granted special measures by you, and we will play that evidence this afternoon. As with previous days, Chair, there may be aspects of today's evidence that are difficult to listen to, and for some people it may not be possible to sit through the two sessions. As with other days, anyone in the inquiry room should feel free to leave at any time. May I take this opportunity, please, to remind those engaging with the inquiry that emotional support is available for all who require it. Present here again today are emotional support staff from Hestia, an experienced provider of emotional support at these types of hearing, and they're currently in this room, I believe, and are wearing orange scarves. There is a private room downstairs where anyone who needs emotional support can talk to Hestia support staff. If you prefer, you can speak to a member of the inquiry team and we will put you in touch with emotional support staff, and we're all wearing purple-coloured lanyards. For those following the hearing online, information about the emotional support that is available can be found on the Lampard Inquiry website at lampardinquiry.org.uk. I'll then move, Chair, if I may, to an update on the Lampard Inquiry's emergency response and resuscitation investigations. Chair, over the course of the last year, you have heard many accounts from bereaved families which have included details of patients being discovered by staff on mental health inpatient units in circumstances of serious medical emergency. A number of those accounts have revealed apparent systemic issues in mental health inpatient care relating to emergency response and attempts to resuscitate. Furthermore, in December last year, Chair, you invited submissions from core participants in relation to the inquiry's work more generally, and these submissions included concerns raised by core participants about the evidence the inquiry has heard in relation to emergency response and attempts to resuscitate. In March this year, having heard the accounts given by the bereaved families and having considered the core participants' submissions, you directed your team to look closely at issues relating to emergency response and resuscitation of deteriorating patients on mental health inpatient units, and you asked us to do so without delay. Put shortly, you considered that some of the evidence this inquiry has heard gives rise to serious questions, amongst other matters, about the recognition of emergency situations, clinical response, emergency decision-making, the availability and accessibility of vital equipment, and the adequacy of resuscitation practices and procedures, past and present, within mental health inpatient settings. You have determined that this is an emerging area requiring investigation because it holds potential implications for the safety of current patients and may also be of national impact. Questions relating to the adequacy of emergency response and resuscitation efforts arise in at least 21 of the inquiry's illustrative cases. Many illustrative case summaries were disclosed to core participants in advance of this hearing. The evidence the inquiry has heard from bereaved families has revealed a number of potential systemic issues that appear to extend across almost all aspects of resuscitation and the processes of emergency response on mental health inpatient units. And those potential systemic issues can be summarised broadly at this stage as, firstly, failures to identify and to understand the true nature of the emergency and to act accordingly. clear issues with sufficiency of knowledge, familiarity with appropriate procedures and equipment, and adequacy of training for staff. Problems with availability and accessibility on wards of vital equipment, and delay at every stage. And with those broad headings or issues in mind, examples of the types of perceived failings that bereaved families have told us about or that have emerged from our illustrative cases include some of the following. Failures by staff to understand the urgency and the nature of self-harm attempts and injuries, delays in responding, and failures in senior clinical leadership. Staff training records showing non-compliance, gaps, and absences in mandatory training. In one case, 7 out of the 10 staff involved in the emergency response were found to have been non-compliant with their mandatory training. An insufficient level or absence of knowledge amongst staff about their roles and their remit during any emergency, the equipment that should be available, where to locate it, how to use it competently. A lack of clarity about whether pinpoint alarms used by staff signified medical or mental health emergencies, and a lack of clarity about who should respond to that alarm. Failures to remove ligatures before attempting resuscitation. Failures to bring appropriate ventilation equipment to the scene, even where such equipment was readily available. Failures where that equipment was brought to be able to locate it within the grab bag and to apply it correctly and without delay. Life-saving equipment being misused, incorrect placement of defibrillator paddles, use of the wrong masks, problems administering oxygen, including failing to appreciate that pull tabs on oxygen cylinders would need to be removed to start the flow of oxygen, or persevering with broken equipment. In other cases, life-saving equipment was missing or broken. There have been delays in staff raising the alarm, with vital minutes lost before emergencies were identified, before appropriate steps were taken, and before emergency calls went out from the ward. Issues with the basic practicalities of making those emergency calls. The basic fact that the situation was an emergency not being explained by those on the ward to the staff who they were calling out, with one case where an on-call doctor was told he had time to get his coat. In one case, that call being delayed because the staff member making the call was unaware that an additional 9 was needed for an outside line. In another, the emergency number for the general hospital resuscitation team had changed without staff on the unit being informed, meaning that the team simply couldn't be reached and alternatives had to be tried, with vital seconds and minutes passing. 999 calls being made by staff on non-portable phones, which were sometimes not available, and who therefore could neither see the patient nor provide proper up-to-date information to emergency service operators. Failures to give clear, accurate information about timings and crucial events to 999 call operators and to attending paramedics, delaying or hampering appropriate intervention further. In one case, a failure to inform paramedics who were attempting resuscitation that the patient had swallowed an item. Paramedics being misdirected in terms of the site or access to the ward, being given conflicting addresses and directions to different entrances. Paramedics being unable to gain access to wards despite having been called out to an emergency, and when that access was gained, further delay while emergency responders were slowed by having to be escorted or allowed through a series of locked doors. In one case, family members who were present in the reception area of the unit having to intervene themselves to assist attending paramedics to gain access to the ward. Attending emergency responders in numerous cases described chaotic scenes on arrival, with ward staff in states of panic, confusion, and disorganisation. Apparent failures in terms of investigations after the event, and the Trust's ability to assess failures and to learn lessons from them, including failures to complete resuscitation event forms. And in terms of potential systemic issues, the real risk that opportunities to identify learning have been lost. Furthermore, Chair, over the past 2 weeks, the inquiry has evidence from staff who currently work on mental health inpatient units in Essex. And this included, for example, the evidence of Brian O'Donnell, who on Wednesday last week shared his concerns as to whether those who were first on the scene of an emergency situation have always received adequate training. And whilst the evidence we have heard and the illustrative cases the inquiry has looked at appeal to reveal systemic issues dating back to the early 2000s, your motivation in considering this topic now is your concern about current patient safety. And you have therefore directed your team to focus on recent policies and procedures and practices and recent training provision and to ascertain the current position. Before I go any further, I'd like to say a little, if I may, about cardiac arrest and secondary cardiac arrest. And we'll hear evidence about this shortly. Cardiac arrest is the ultimate medical emergency. It's defined by the absence of a person's normal breathing and/or signs of life. And when a person is in cardiac arrest, their heart stops pumping blood around their body and they lose consciousness. And we will hear that without cardiopulmonary resuscitation, also known as CPR, and where indicated defibrillation, a person will not survive a cardiac arrest. CPR is the combination of administering chest impressions and delivering rescue breaths. In acute clinical settings like general hospital wards, CPR is supplemented by additional key skills which are provided by a specific expert team, often called the cardiac arrest or resuscitation team or crash team. This team will be mobilized to attend a patient when a cardiac arrest call is made. But this is unlikely to be the position or the provision in many mental health inpatient units, however. A significant proportion of cardiac arrests that take place in healthcare settings, and in particular in mental health inpatient settings, are what are known as secondary cardiac arrests. Secondary cardiac arrests are a patient's response to a preceding clinical event or trigger. And examples of trigger events include many of those common to mental health inpatient settings, such as low oxygen levels, hypoxia, airway obstruction, overdose, severe physical deterioration, and ligature-related asphyxia. And in circumstances where there has been a trigger event, such as those I've just described, a patient goes into cardiac arrest at the end of a process. And that process includes deterioration of the patient's loss of consciousness, and the patient stopping breathing. And secondary cardiac arrests usually result in non-shockable heart rhythms. And this means that the use of a defibrillator, which works for shockable rhythms, is not usually indicated for secondary cardiac arrests. And survival rates of secondary cardiac arrests are therefore poor. Secondary cardiac arrests therefore need to be managed differently, depending on the trigger event. For example, if a patient goes into cardiac arrest secondary to low oxygen levels, hypoxia, a key treatment is to manage the patient's airway and provide high concentration and high flow oxygen by providing artificial ventilation, along with the CPR. In mental health inpatient settings, those who are first on the scene of a medical emergency should provide treatment to the level they've been trained at the same time as urgently summoning expert help. In circumstances where secondary cardiac arrest has not yet occurred, there may be an opportunity to identify deterioration and intervene before that secondary cardiac arrest takes place. And we'll hear evidence about that from Resuscitation Council UK, or RCUK, this morning. On a mental health inpatient unit, preventative measures might include removal of the ligature, recognition and prompt management of an airway or breathing compromise, monitoring and escalation of deteriorating vital signs, management of overdose or intoxication, and an early transfer or escalation to acute medical services. Any delay could be fatal. And given the massive impact that certain skills and intervention may have on the outcome for a patient, one of the issues this inquiry intends to investigate is the level and type of training that could or should be provided to those who might find themselves as first responders on mental health inpatient units, and which elements of training specific to mental inpatient units should be included. With regards to the expert help to be summoned, in a mental health inpatient setting, this might be a cardiac arrest team, depending on the location of the unit, but more commonly, it will be the ambulance services, or in the interim, ward staff who are trained in more advanced resuscitation skills while they wait for the larger team to attend. The inquiry also intends to look at what sorts of arrangements could or should be in place on mental health inpatient wards to ensure that the expert help can be called quickly, and most importantly, to ensure that the help can get onto the ward and to the patient without confusion and delay. And we will hear some evidence today, Chair, that the window of opportunity to influence the outcome for these sorts of emergencies is small. It would appear, therefore, to be of paramount importance that those who are first on the scene can identify the emergency and the signs of deterioration, that they know what to do, that they have access to the equipment and the drugs they need to treat the patient, that there are suitably trained staff available to lead the emergency response and resuscitation attempt, that there are systems and resources in place to summons expert help, that there are processes by which that expert help can gain access without delay, and so on. And these are all matters that you have directed your team to look at, Chair. And to this end, then, may I say a brief word, please, about life support training. Basic life support, or BLS as it's sometimes known, training, teaches the basic set of first aid procedures needed to keep someone alive during a life-threatening emergency before advanced medical help arrives. Anyone can undertake basic life support training, and many do, in the workplace, for example, or at sports clubs, or as volunteers in the community. BLS training often includes the use of automated external defibrillator, AED, which provides prompts. Immediate life support, ILS, training is more comprehensive, and it's aimed at healthcare professionals who may have to act as first responders in emergency situations. And it provides those healthcare professionals with the additional skills required to manage patients in cardiac arrest before expert help arrives. And ILS training may also be suitable for other types of first responders, such as police officers or air stewards. ILS training can teach a variety of skills, including managing a deteriorating patient, identifying causes, and treating cardiac arrest. You do not have to be clinically trained to undertake ILS training. Advanced life support, ALS training, is, as its name suggests, advanced. And ALS training is designed to ensure that healthcare professionals are equipped to recognise and manage cardiac arrest situations and can lead or work effectively within a resuscitation team. A healthcare professional requires certain relevant clinical qualifications before they can undertake ALS training. When I have finished this update, Chair, we will hear evidence from Adam Benson-Clark, the Director of Clinical and Service Development of Resuscitation Council UK. Mr. Benson-Clark is also a registered nurse. RC UK is a non-statutory, charitable incorporated organisation which describes itself as dedicated to saving lives by developing guidelines, influencing policy, delivering courses, and supporting innovative research concerning resuscitation practice. RC UK are the organisation responsible for issuing resuscitation practice guidelines and standards for the healthcare sector throughout the UK. RC UK develop and publish the quality standards for cardiopulmonary resuscitation practice and training, and they're known as the quality standards for healthcare organisations to follow. These standards are based on the most recent RC UK resuscitation guidelines, and we will look at some of the relevant parts of the quality standards with Mr. Benson-Clark this morning. The quality standards reflect a number of different types of settings where clinical care is provided and where resuscitation may be required. and one of those settings is mental health inpatient care, which is sometimes known as MHIC for the purpose of the standards. Chair, there has been a wealth of relevant policy, review and guidance issued or published on this topic over the course of the period the inquiry is investigating, which I will not rehearse for the purpose of this update. They've included, but are not limited to, NICE guidelines, guidance issued by the Royal College of Psychiatrists, DHSC guidance on the use of force, for example, health service circulars, and previous guidelines published by RCUK. The current introduction and overview to the RCUK quality standards was first published in November 2013 and was last updated in May 2020. The sections on mental health inpatient care and equipment and drug lists for mental health inpatient care were first published in May 2014. And that was the first time that formalised national standards had been published by RCUK in respect of mental health inpatient care. And they too were last updated in May 2020. The Royal College of Psychiatrists was one of the organisations that contributed to the quality standards and were on the working group, but there does not appear to have been any input from a mental health nurse, for example, and it's unclear to the extent to which the standards reflect the experience of those with on-ward experience in mental health inpatient units. The RCUK Quality Standards Introduction Overview set out 9 core standards, which we will look at shortly. Number 1 is that the deteriorating patient is recognised early and that there is an effective system to summon help in order to prevent cardiorespiratory arrest. Number 2 is that cardiorespiratory arrest is recognised early and cardiopulmonary resuscitation, CPR, is started immediately. Number 3 is that emergency assistance is summoned immediately as soon as cardiorespiratory arrest is recognised if help has not been summoned already. Number 4 is that defibrillation, if appropriate, is attempted within 3 minutes of identifying cardiorespiratory arrest. Number 5, appropriate post-cardiorespiratory arrest care is received by those who are resuscitated successfully, and this includes safe transfer. Number 6, implementation of standards is measured continually and processes are in place to deal with any problems identified. Number 7, staff receive at least annual training and updates in CPR based on their expected roles. Number 8, staff have an understanding of decisions relating to CPR. And number 9, appropriate equipment is available for resuscitation. The quality standards for mental health inpatient care provides a framework, and it outlines RCUK's expectations for CPR practice, governance, training, equipment and medication provision, and emergency response arrangements within mental health care providers' organisations. The equipment and drug lists set out RCUK's position on the minimum resources required to support effective resuscitation. As for the status of the quality standards, RCUK state that their quality standards are intended to support organisations in developing local systems, policies and training arrangements appropriate to their clinical environment, patient population and available resources. RCUK does not mandate implementation of their standards, and RCUK does not operate any formal compliance, accreditation or assurance process in relation to the adoption of their standards within mental health inpatient providers. And furthermore, as the inquiry understands the position, no separate organisation undertakes accreditation processes, nor inspects, nor regulates specifically the implementation or operation of RCUK standards in any setting. Formal regulatory oversight of inpatient mental health care providers in England, including provision relating to emergency response, sits principally with the Care Quality Commission, the CQC, of course. And RCUK doesn't direct the CQC's inspection methodology and does not receive routine provider-level assurance information about the implementation of RCUK quality standards. And when Mr. Benson-Clark gives his evidence this morning, we'll look at the relevant parts of the RCUK's quality standards that relate to mental health inpatient care, and that those which indicate that certain units should have in place particular processes for resuscitation in special circumstances. Those circumstances include suffocation, application of ligature, self-harm, seclusion, and rapid tranquilization. We will also hear that the quality standards are due for review later this year. In respect of restrictive interventions, Chair, there has long been guidance in relation to restrictive interventions. The CQC has separately issued a brief guide, immediate life support training for services that may use restrictive interventions, which in turn refers to NICE guideline NG10. NG10 recommends that in any setting where restrictive interventions, rapid tranquilization, restraint, or seclusion are used, there should be immediate access to staff trained in ILS and to appropriate ILS medication and equipment. The CQC guide also refers to the recommendations within RCUK's quality standards. EPUT have already informed the inquiry that for a period of time, at least from November 2019 to March 2023, they interpreted NICE guideline NG10 for a setting where restrictive interventions may be used as requiring access to BLS-trained staff rather than ILS-trained staff. As previously outlined, Chair, one of the issues this inquiry intends to look at in relation to this topic, particularly given the need for staff to be able to identify immediately signs of deterioration in a patient to prevent a secondary cardiac arrest if possible, and the importance of the role of those who are first at the scene, is what level of training could or should be given to which staff working on mental health inpatient units. We will hear, for example, that whilst RCUK doesn't expect all healthcare assistants working on mental health wards to have ILS training as a blanket requirement, their quality standards do set out what RCUK consider to be the minimum skills required for staff who respond immediately. Staff who respond immediately are the ward staff or other locally designated staff who are expected to provide the initial resuscitation response to a patient who has collapsed or who is in cardiorespiratory arrest before the arrival of the cardiac arrest team or ambulance clinicians or other staff trained in advanced resuscitation skills. RCUK recognise that these first responding staff may well include healthcare assistants, for example. And the inquiry is aware, through evidence from bereaved families, through staff witness accounts such as that of Brian O'Donnell, and through its illustrative cases, that healthcare assistants will often be the first on the scene. RCUK provides education and training through its own resuscitation courses and associated guidance issued to RCUK registered course centres. These course centres include NHS trusts, private healthcare organisations and providers of mental health inpatient care. RCUK are not, however, the only providers of life support training. According to RCUK, their ILS training was developed for healthcare professionals who may have to act as the first responder in an emergency. Its purpose is to give individuals the skills to recognise the deterioration, to identify the cardiac arrest, and start immediate resuscitation, use defibrillation where appropriate, summon expert help, and manage the patient until a cardiac arrest team, ambulance clinicians, or other advanced responders arrived. It is not designed, that is the ILS training, is not designed to provide comprehensive training in the definitive management of every special circumstance listed. Within its ILS training, RCUK has developed mental health specific ILS course materials and simulation scenarios for healthcare professionals working in mental health inpatient settings. And we will hear that these include scenario-based training content, assessment materials, and instructor resources intended for mental health environments. And we will hear evidence as to RCUK's view of the importance of simulated and scenario-based training for all of those working on an inpatient mental health unit, and for the importance that that training should take place as a team, if at all possible. But as previously stated, Chair, RCUK is a non-statutory professional body. It's not a regulatory or inspection organisation. It does not mandate, oversee, nor monitor implementation of its quality standards within individual providers. RCUK does not routinely liaise directly with NHS trusts or private providers of mental health inpatient care regarding the implementation of its standards. Implementation and organisational responsibility sits with providers. Health Service Circular Series number HSC 2000-028, which was published as far back as September 2000, stipulates that chief executives of all NHS trusts should give a non-executive director designated responsibility on behalf of the trust board for ensuring that a resuscitation policy is agreed, implemented and regularly reviewed within the clinical governance framework. Chair, the inquiry has requested and received evidence on this topic from each of the core participant trusts and providers. Our aim, as directed by you, is to ascertain and examine, where possible, the reasons behind apparent systemic failures in emergency response and attempts to resuscitate. And those focused evidential requests therefore included requests for relevant policies and procedures in place at each of the core participant trusts or providers, with a focus as directed by you on recent years and current provision. Requests for each trust or provider to identify where those policies and procedures departed from and or modified the RCUK standards or national policy or NHS England guidance, and to include any departure from guidance or quality standards produced by NICE. They included requests for evidence in relation to any local variation included in trust provider policies and procedures in respect of individual mental health inpatient units or specific wards, and any local agreements that were in place between such units and wards and acute services or with nearby accident emergency departments. They included requests for evidence relating to the training of staff on mental health inpatient wards in respect of emergency response and resuscitation. We have asked questions about all staff, clinical and non-clinical, nurses, doctors and healthcare assistants, bank staff and agency staff. And we've requested information on the courses that were available, whether they were mandatory, when staff were required to complete them and how regularly they were required to repeat them. We've asked about practical elements and scenario training, assessment of trainees and monitoring of training completion. We've also asked about any adaptations that were made to training to make it ward, unit or patient specific, and where applicable, any differences in the policies, procedures and training provided in respect of adult patients and child patients. And we've made requests for evidence about any modifications to trust provider policies and procedures made during the COVID-19 pandemic, and whether those modifications are still in place. This is also an area, Chair, where you considered it important to identify how arrangements in Essex compare with the provision in other trusts across the UK, and to explore whether any challenges identified in trusts and providers in Essex are, in fact, national challenges. The inquiry therefore asked the same questions of 4 other UK trusts, NHS trusts: North Staffordshire Combined NHS Trust, Northamptonshire Healthcare NHS Foundation Trust, Hertfordshire Partnership University NHS Foundation Trust, and East London NHS Foundation Trust. You consider that evidence from comparator trusts will assist you in setting the evidence the evidence you receive about practice and procedure in Essex into its proper national context. And furthermore, given that the inquiry has identified cases illustrating apparent systemic issues at EPUT, the Priory Group and St Andrews, the inquiry has asked those providers to set out details of where and how learning from any failings were identified, disseminated, what action was taken, including how those actions were implemented, reviewed and monitored to ensure that learning was effectively embedded and sustained and applied in practice. In respect of EPUT more specifically, where a systemic issue had been identified in one case but apparently repeated in later cases, we asked for an explanation of why that systemic issue had reoccurred and whether any action had been taken now to prevent the future reoccurrence. Those witness statements, Chair, recently received from both Essex providers and the comparator trusts I've referred to, have already been disclosed to core participants with a significant number of exhibits to follow. And the inquiry intends now to undertake appropriate analysis of whether and how the policies, procedures, practices for emergency response and resuscitation in place at the trusts and providers in Essex reflect proper standards and guidance. We also intend to explore whether the provision now in place is sufficient for the safety of current patients, taking into account, where necessary, appropriate local operational needs and the reality of day-to-day working on a mental health inpatient ward. And we intend to review carefully whether lessons have been learned from previously identified systemic failures in relation to emergency response and resuscitation, or whether history has been allowed to repeat itself. The inquiry will not hear the evidence from the individual trusts and providers during this hearing. The inquiry intends to explore these matters and consider any analysis more broadly as part of the reframed interim recommendations hearing in October. The inquiry is also in the process of currently engaging with others, including those with relevant expertise who we consider may be able to assist you, and we're actively exploring what data is available. Finally, Chair, the inquiry is grateful to the core participants for their input and engagement into this topic thus far. Chair, that update having been completed, can I invite you to take a 10-minute break and come back at 10:50 to allow, I think, Mr. Benson-Clark to come back and for arrangements to be made?
It's until 10:50.
Thank you.
Ms. Harris.
Thank you, Chair. Could the witness be sworn, please?
Thank you. That's fine, thank you. I, Adam Benson-Clark, do solemnly and sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Good morning.
Good morning.
Thank you very much. I know you've just referred to it in your affirmation, but can you state your full name for the record, please?
Adam Benson-Clark.
Mr. Benson-Clark, you have provided two witness statements to the inquiry. The first is dated the 15th of May 2026, and the second is dated the 22nd of June 2026. And you should have a copy of both of those statements in front of you. Mm-hmm. I see you're nodding. Would you be kind enough to say yes?
Sorry, yes.
Your evidence is being transcribed, so if you could confirm, that would be very helpful. You have signed the final page of each of those statements?
Yes.
Which contained a statement of truth?
Correct.
And can you confirm, in fact, that your second witness statement is an updated and revised version of the first statement?
That is correct.
You having been asked some follow-up questions by the inquiry?
Correct.
Have you had an opportunity to read those statements recently?
Yes.
Is there anything you would wish to change in those statements?
Nothing to update.
And do you stand by those statements?
I do.
Well, those statements, and in particular the second updated statement, form the basis of your evidence to the inquiry, along with the answers that you give today. I will refer to paragraphs predominantly in your second witness statement when asking you questions, but there's no need to read the statement out in full. And in fact, I've already referred to quite a lot of your evidence during an update I just provided to the chair, so we may be able to move through some parts of it quite quickly. You've also provided, I think, 26 exhibits.
Correct.
By way of background, you are the Director of Clinical and Service Development of Resuscitation Council UK.
Correct.
It's a registered charity.
It is.
And you were appointed to the role in April 2026.
Correct.
I think you held the position of interim director before that, since last November.
Correct.
And prior to that, you were the deputy director?
Correct.
From about June 2023?
Yes.
And before that, you were courses manager stroke clinical lead from 2017 to 2023.
That's correct.
And you are giving evidence here on behalf of Resuscitation Council UK, which I think is sometimes known as RC UK for short. Is
That's
that right?
correct, yes.
Well, we might do that, stop me stumbling over it. And we know from paragraph 3 of your witness statement, and I'm not going to ask you about it in detail, that you're giving evidence on behalf of Resuscitation Council UK, but some of the information within the statement was provided by others.
Correct.
You are also a registered nurse, we see.
I am.
When did you qualify as a nurse?
In 2006.
Are you still in clinical practice, or are you now working full-time for RC UK?
I work full-time for RC UK, but maintain the requirements for my professional registration.
As a nurse, did you work in hospital, on hospital wards, or in the community?
So my role was very much in acute hospital settings.
And as a nurse, were you ever involved in a resuscitation event?
Many times I specialised in resuscitation in the hospital setting.
When was RC UK first formed?
So it was formed in 1982 or 83. It's over 40 years old, by a group of clinicians who recognised there was a gap and lacking within UK healthcare systems for resuscitation training and governance and practice. So this group of clinicians then formed the Resuscitation Council to sort of embed clinical practice and training throughout the UK.
And does that remain its purpose?
Yes, we've extended slightly. So our core remit at the moment is we write the national guidelines for resuscitation for the UK, which are based on the European Resuscitation Council guidelines and consensus statements from the International Liaison Committee on Resuscitation. So that information creates the guidelines for the UK. We write the quality standards for healthcare organisations, which enable them to provide robust quality resuscitation services within their organisation. We also fund resuscitation research throughout the UK. We also have a strong campaigns and policy arm where we will look at where there's discrepancies or opportunities to enforce resuscitation, either education. So one of our big campaigns was resuscitation in schools to get it on the national curriculum. We're also looking at survivorship post-cardiac arrest and looking at how there's disparities within healthcare within the UK about what level of care you might receive once you get discharged from hospital. So we're looking at how we can influence on a national scale policy that comes from government. So we've got quite a few different arms, and obviously the educational components which relate to our courses.
I was about to say, you also deliver courses.
We do.
You describe in your witness statement the core membership of RC UK, and you say, this is paragraph 5 for those who are following it, and I don't necessarily ask you to turn to it, Mr. Benson-Clark, but you say the core membership comprises clinical and academic experts recognised as international leaders in resuscitation, but it does not currently and has not previously included any qualified psychiatrists, psychologists or mental health nurses or anyone else whose principal role was within inpatient mental health services. So is that right?
That is correct, yes.
So what do the core membership do?
So the way that we work as a charity, we have a board of trustees, which has 4 clinicians and role of president, vice president, treasurer and honorary secretary. But our constitution is written so that there will always be a greater element of clinicians, and then we have 3 appointed trustee members who are lay members of the public or people from industry. They govern the organisation, and below that feeds into what we call our executive committee. These are the chairs of our course and clinical subcommittees, as well as people who are elected in via our membership. So these individuals very much make up people who've got high level of academic interest in research, in resuscitation science, or recognised clinical experts in resuscitation science as well.
You also explain at your paragraph 6 that you have a much wider membership, a much wider membership, in fact, over 15,000 specialist healthcare volunteers who you say provide training to over 150,000 members of the UK healthcare sector every year to your recognised standards.
That's correct.
You've been asked about the makeup of that wider membership, that much wider membership, but I think you've explained, and this is again at your paragraph 6, that you don't collect demographic or professional qualification data in a way that allows you to identify, for example, how many are volunteers who are qualified psychiatrists, psychologists, or mental health nurses.
That's correct. We collect baseline demographic data. We're expanding that remit currently, but we can identify who are nurses, who are doctors, paramedics, if they work in acute or community, but not down to the level of if they are sort of a mental health registered nurse.
At paragraph 7 of your statement, you describe RCUK as the organisation responsible for issuing practice guidelines and standards. You've already explained how that works. And you've said that your practice guidelines and standards development process is conducted to the highest standards. And sorry to ask what might seem an obvious question, why is it that you are confident that your guidelines and standards are developed to the, or processes to develop to the highest standards?
So it starts very much from the International Liaison Committee on Resuscitation. So they look at a group of questions, and the recent guidelines cycle, I believe there was about 250 questions that they asked looking at resuscitation science, which goes through an international peer review process and public consultation. That information is, those recommendations then distilled into a Continental Resuscitation Council, so in our case that's the European Resuscitation Council. Again, that's distilled and has a public consultation looking at that, and it then comes to the UK and we use that information. As part of that process, we also follow what was the NICE recommendation, so the National Institution of Clinical Excellence. They had a process of validating and recognising specialist organisations' guidelines and recommendations that we'd written. So we recognise that we are the experts in resuscitation. We would follow their guideline process manual, which goes through very stringent remit of what it takes to get that NICE accreditation. They withdrew that in 2024, but we still maintain and follow what were those recommendations to provide ourselves rigour and accountability for what we produce.
Just in terms of withdrawing accreditation in 2024, what is the background to that?
It was a decision that NICE made. I can't recall off the top of my head. It did cause concern with some of the other charitable bodies and organisations because it looks on face value that we've had the accreditation taken away, but NICE are very clear that we can add a statement to our regulations and guidelines to say that they are still of the standing. It's just that NICE are no longer accrediting external guideline processes.
Do others provide such accreditation?
No other organisation I'm aware of.
And will that have happened to other organisations?
Yes, yes.
Can you give me an example?
Not off the top of my head. Sorry.
Perhaps you could let us know.
Certainly.
Before I go on to ask you about your guidelines and your standards, can I ask you to help us a little bit about cardiac arrest and secondary cardiac arrest, which you deal with in your statement? And to go straight to it, at paragraph 9 of your second witness statement, you describe cardiac arrest as the ultimate medical emergency. You're nodding, can you?
Yes, sorry, yes. No, it very much is the ultimate medical emergency. It's time critical where seconds count.
Sorry, time critical.
It's time critical.
And in terms from what happens from a clinical perspective, is this right? When a person is in cardiac arrest, their heart stops pumping blood around their body.
Correct.
And that's different. I know it seemed like an obvious thing to say from a heart attack, say, where the heart continues to pump.
That's correct, and a lot of people get the two terms very much interchanged and confused. So a heart attack is where you have a blockage within the main blood vessels which supply the heart with oxygenated blood, the coronary arteries. When that happens, the muscle of the heart starts to die very quickly. A severe heart attack can lead to a cardiac arrest.
That was my next question.
And that is where we have the heart stops pumping blood, oxygenated blood around the body, and we need to try and restart that heart.
Going back to cardiac arrest then, without cardiopulmonary resuscitation, can we call it CPR for the purpose of the questions, please, and defibrillation, and we'll come back to defibrillation in a moment, a person will not survive a cardiac arrest?
You can't survive a cardiac arrest without medical intervention. So you need good quality CPR, so chest compressions and ventilation to buy yourself time. If the heart has gone into an abnormal rhythm where a defibrillator will work, we need to shock it to get it back into a normal rhythm. But CPR and good management of the airway and providing ventilation buy you time for advanced resuscitation to hopefully reverse what's caused the cardiac arrest.
There may be people that are not fully familiar with CPR, so can I just ask you to explain what CPR is, please?
So CPR is the act of rhythmically putting pressure on chest compressions onto the chest. So you're compressing the heart, so you are physically pumping the blood around the body. Including with that, we do ventilation, so we're providing oxygenated, we provide oxygen, we inflate the lungs ourselves to try and get oxygenated blood circulating around the body to preserve those vital organs, so predominantly the heart and the brain.
And in terms of providing ventilation, providing oxygen, that can begin with rescue breaths?
Yes, that is, yes. Correct.
Although I think it's, in adults, and we come back to this in a moment, just the chest compressions to start off with are the key point, is that right?
So within the guidelines algorithms, we always start with chest compressions, predominantly for adults. If people are untrained, unwilling or unable to provide ventilatory breaths, you can do CPR for a period of time without providing ventilation, because we've got good-sized lungs which should be filled with oxygen, which help if the collapse has been sudden. For particularly children, they have a much more higher oxygen demand, and their type of cardiac arrest is more oxygenation and respiratory driven, and therefore breathing is much, much more important and relevant for that part of CPR.
Because I think, as you say in your statement, it provides that immediate, and sometimes might even remove minor blockages in a child.
Correct.
You go on to explain in your statement that in a hospital setting, and can I just check what you mean by that? Do you mean an acute clinical setting when you talk about a hospital setting at your paragraph 10?
In relation to, sorry, if we can expand that question, sorry.
So you go on to say that in a hospital setting, CPR is supplemented by additional key skills provided by the cardiac arrest resuscitation team. And I just wanted to see what you meant by hospital setting there.
So actually that could be any setting really. So when you start cardiopulmonary resuscitation, so CPR, you're very much providing basic level life support, chest compressions and ventilation. There are elements where, depending on where you're situated, you might need more advanced skills to help manage that situation. And that is where that element of additional skills in that setting arises. That in a community setting might be by calling an ambulance and getting highly trained paramedics to come along to the cardiac arrest or medical emergency, or in a hospital setting, you've got teams who have much higher level skills, so anaesthetics to manage an airway, a very senior medical physician who might think more broadly about the cardiac arrest management in itself.
I think I wasn't, sorry, it may be that my question wasn't clear. I think what I was trying to, and we'll come back to it in a moment, I was drawing a comparison with, say, for example, a mental health inpatient setting, which is unlikely to have the cardiac arrest team, resuscitation team at its disposal in the same way as you would in an acute clinical.
They should have a team or a response team, which would be a cardiac arrest team, but the skill level may be slightly different, absolutely.
There is, of course, occasionally a co-location. So if you have a mental health inpatient unit that is co-located with an acute clinical setting, there may be easier arrangements depending on
Correct.
Contracts.
That's correct. They can often be supported by the main hospital resuscitation team.
When you talk in terms of CPR being supplemented by additional key skills, looking again at your paragraph 10, are the additional skills you're referring to advanced airway management?
It certainly can be advanced airway management, so looking at tracheal intubation, so putting a breathing tube beyond the vocal cords into the windpipe. That is very much an advanced skill that isn't common to a lot of healthcare professionals who haven't had additional training.
We'll come back to the training and what you might learn on what training in a moment. But just looking in terms of skills, so we have advanced airway management, defibrillation.
Defibrillation can be a basic level skill. There are two types of ways we can really deliver defibrillation. So one is using an automated external defibrillator. They're the ones you see in train stations in the public, which will do the job for you. They might ask you to press a shock button or not, but they analyse the heart rhythm, do levels of interpretation. Or it might be manual defibrillation, which is more of an advanced skill, which can be done at an intermediate level or an advanced level, where you, as a clinician, are interpreting the heart rhythm to decide whether or not to deliver that shock.
Mr. Benson-Clark, I'm sorry to just stop you for a moment, but I'm being asked if you could slow down a little bit. No, you're giving a lot of very important detail, and it's very important that what you say is we can transcribe and make a record of it. So I will remember to slow down as well, but if I stop you from time to time, that is why. So thank you very much. We were talking about the additional skills. You were explaining about defibrillation. Resuscitation drugs you list in paragraph 10, is that again, for a more specialist team?
That'll be an advanced team. Majority of cases would require someone who is a qualified and licensed prescriber, or have clearance if you hold an advanced resuscitation provider certificate under the human medicines regulations, which allow providers of advanced life support certificate of adults to give drugs in cardiac arrest for adrenaline amyodrome. But they
hang on, sorry, you said that so quickly. Yes. I'm afraid I didn't hear a word.
No,
if you do tend to speak fast, so apologies.
Can you really try and slow down?
Certainly. So, in terms of drugs within a cardiac arrest, it's very much within the remit of advanced resuscitation. The reason being is that individuals usually have to have a license or qualification to prescribe medication. There is a cover from the human medicines regulations, which allow individuals in adult resuscitation only, so it doesn't relate to pediatrics. If you hold an advanced qualification with Resuscitation Council UK, an ALS certificate, you can give adrenaline and amyodrone as the two main cardiac arrest drugs under that exemption from the regulation.
And just to complete the list of the additional skills you refer to at paragraph 10, you list looking after the patient and then leading the team.
Yes.
Including someone to identify what the underlying cause of the cardiac arrest may be.
Absolutely.
You go on to explain at your paragraph 11 that a significant proportion of cardiac arrests that take place in healthcare settings, and in particular mental health inpatient settings, are what is known as a secondary cardiac arrest.
Correct.
Before I ask you about that, shortly, what is a primary cardiac arrest?
So when we term things as a primary cardiac arrest, it's usually due to the heart as a primary organ. And that could be due to an acute coronary syndrome, so that is a heart attack, a severe heart attack which has caused a cardiac arrest to happen. It can be either due to structural problems with the heart, so hypertensive valve disease, so people might have higher levels of blood pressure, put strain on the heart itself. It can also be due to electrolyte abnormalities, so things like potassium, which is a very key regulator for how your cells work and how the heart works. So these type of things which may cause abnormal heart rhythms, that is a primary cardiac arrest, and these are usually treated with defibrillation. Secondary cardiac arrest is where it's happened at the end of a disease process or a problem, so elements like asphyxia, where you've got low blood oxygen levels.
Can I just pause you for a moment before we go on to secondary cardiac arrest? Just going back to a primary cardiac arrest, and one of the causes you've explained is electrolyte abnormalities or imbalances. Can I just ask you this specific or discrete question? Would those electrolyte imbalances arise, for example, in circumstances where there was malnutrition or where a person had an eating disorder or something of that nature?
Certainly can do. So if you are malnourished or dehydrated, which can happen with people with eating disorders, you do get electrolyte imbalances. Where the body gets so, the word's cachectic, so it gets very emaciated, it starts eating its own muscle, and it can start then, and it doesn't exclude the heart muscle in that sort of sense. So therefore you can get some slight structural changes to the heart, which can cause problems. There's also challenges in the management of eating disorder where you start to introduce food back to an individual and you have to monitor their electrolytes very carefully because you can get a condition called refeeding syndrome, which is where you get spikes of insulin within the body and that causes some of the electrolytes like potassium to be pushed into the cells and therefore that can cause an arrhythmia. So it takes specialists to manage that level of balance with those. But all of those can cause that primary cardiac arrest.
So that was primary. Sorry, sorry.
Can I-
No, sorry, Chair, cool.
I don't want to interrupt that, but you were very clear at the beginning that there's a distinction between heart attack
Yes.
and cardiac arrest. But there may be cases you're suggesting where heart attack, in a sense, becomes cardiac arrest.
Correct. It can lead, a bad heart attack can lead to a cardiac arrest. So where you've got a blockage in the blood vessel which feeds the heart muscle, and that heart muscle dies, it can affect the electrical current of the heart, and that can lead to a cardiac arrest. It's a very, very severe heart attack which will lead to a cardiac arrest.
Thank you. Sorry to interrupt.
No, not at all. Thank you, Chair. You were beginning to give us some examples of events that might trigger a secondary cardiac arrest. And I'm going to ask you, if I may, to focus on the kind of examples that might feature on a mental health inpatient unit. And at your paragraph 11, you list low oxygen levels, so hypoxia, airway obstruction, overdose, ligature-related asphyxia, and severe physical deterioration, all as possible triggers that would give rise to a secondary cardiac arrest. Have I understood the position?
Yes.
And you go on to explain what happens in a secondary cardiac arrest. And the cardiac arrest, as I think you began to explain, happens at the very end of the process that starts with the trigger event.
Correct.
And then the patient deteriorates.
Correct.
The patient loses consciousness.
Correct.
The patient stops breathing.
Correct.
And correct me if I'm wrong as a layperson, is that the point when you would say the person is in cardiac arrest?
So the point of recognition is not breathing or not breathing normally. We would say they're in a cardiac arrest. We don't emphasise for individuals to check pulses unless they're advanced trained, because in extreme situations, we know that people don't. It can be quite difficult to palpate a central pulse on an individual to see if their heart stopped pumping. So our baseline is, if they're unresponsive, not breathing normally, we assume everyone is in a cardiac arrest, and we'll start treating them as such.
As if it were cardiac
As if it
arrest.
were.
And it may follow, in fact, from your last answer, that would you agree that the trigger clinical events can very rapidly cause a person to lose consciousness and suffer that cardiac arrest?
Certainly, yes.
Which may result in death.
Absolutely.
One of the key differences between a primary cardiac arrest and a secondary cardiac arrest, if we understand your statement, is that a primary cardiac arrest will result in what's known as a shockable rhythm, whereas a secondary cardiac arrest results in a non-shockable rhythm. Have I oversimplified that?
Essentially, that's correct. So in the primary cardiac arrest, predominantly they will be shockable. Means the defibrillator is what we need. The heart's gone into a chaotic rhythm or abnormal rhythm where we know defibrillation has the highest chance of getting a normal heart rhythm back, and therefore a higher chance of survival. Because in a secondary cardiac arrest, we've got that period of deterioration, we have to figure out and reverse that cause, because defibrillation won't work. The rhythm could look normal, but the heart might not be pumping. Or in worst case scenarios, we get a rhythm which is what's commonly termed as that flat line, which is called asystole. Both of these don't work with defibrillation. We need to give drugs, adrenaline, to try and reverse that, as well as look at the reversible causes. So in a case of like a hypoxia injury, we need to give them high flow oxygen, high levels of oxygen to try and reverse that.
So
but they have worse survival rates.
I'm going to pause you because you're giving a lot of information very quickly. No, it's very helpful, and it's obviously a very important information. So going back then to your shockable and non-shockable rhythms, as you've explained, you have to give. With non-shockable rhythms, you give the drugs, and you try and reverse it. And we'll come to it in a moment. But as we look through the standards and we look through the guidelines, defibrillation is mandated or in any event. So help us with this. Do you still recommend, mandate, whatever, and to what extent, a defibrillator even though you know you're working with a secondary cardiac arrest. Does that make sense?
Yes, and absolutely we would do for all age groups, for children and adults. If someone is in cardiac arrest, we want the defibrillator on.
Can I just stop you? So why would you use a defibrillator in circumstances where there is a non-shockable rhythm?
So
For those of us who are lay people.
depending on the type of defibrillator, it might have a monitor as part of it, so we can see what the rhythm is doing. If it doesn't have a monitor on there, we want to ensure it's there because actually some of the management for a non-shockable cardiac arrest, so in the secondary cardiac arrest, if we give someone adrenaline, say, that might actually put them into a shockable rhythm, and we would then need to give a shock quickly.
Sorry, say that again.
So in a secondary cardiac arrest, where it's typically non-shockable in that first instance, giving adrenaline to an individual might actually cause them to go into a shockable rhythm in a small number of cases. The reason we want that defibrillator on is because actually the longer it takes us to provide that defibrillation, that shockable rhythm degrades and goes into a asystole, that non-shockable rhythm where the defib won't work. So it's about that time critical instance of getting that shock in early if it's required.
So I'm going to put it, if I may, simply. You have the defibrillator because if that rhythm becomes shockable, you need to shock it.
Absolutely.
First of all, you need to see it if there's a monitor on it straight away, and you want to shock it straight away.
Correct.
Returning then to secondary cardiac arrests and deteriorating patients on mental health inpatient units, and given they, as I say, second cardiac, is it right that they need to be then, we've talked about the defib, but they need to be managed differently in essence, in that the first on the scene need to do two things, I think you say in your statement. Firstly, they need to intervene straight away and provide the treatment to the level they're trained to provide.
Correct.
At the same time as calling for expert help.
Correct. And that's the same for all healthcare organisations.
Now, we'll come back to calling for help in a moment, but can we consider how the first person on the scene might be able to intervene? So if we understand your witness statement overall, please correct me if I'm wrong, and I've got reference here for those who are following the witness statement to paragraph 12. If the patient is found quickly enough after the trigger event, and can I just say that would have to be very quickly, wouldn't it?
Exceptionally quickly, yes.
How quickly?
Depending on what the trigger was, so something like a ligature, you really want that as soon as possible, very closely afterwards. Anyone who has a collapse, you want to get them as basically as quickly as possible. It's difficult to put a time frame.
But we're talking seconds and minutes rather than...
Seconds and minutes has the greatest chance of survival.
So as I say, if the patient is found quickly enough and the person who finds the patient has the right sort of training, so knows what to do, and can identify signs of deterioration, then depending on what caused the emergency, that person might be able to intervene to stop the secondary cardiac arrest happening at all. If I understood your statement correctly.
If they've been found unresponsive, we would say to assume them to be in that secondary cardiac arrest, certainly if they're not breathing normally. So in that case, that individual should start by shouting for help to get someone around them, activate the local emergency buzzers if there's whatever's in that local vicinity to get other people to help. They certainly don't want to be managing this in isolation. You need more people around you to help manage this event. And in which case, if there's something like a ligature, they might have a ligature cutter to hand, say, and they can get that off relatively quickly, hopefully. But then they're looking at starting the chest compressions and doing that basic level life support whilst waiting for other people to come to help.
Can I just pause you for a moment?
Yes.
So would you agree then that the key thing to avoid or the key moment to avoid, I know you say you treat it as if it were a secondary cardiac arrest, but the key thing to avoid, if at all possible, is that patient going into secondary cardiac arrest?
Certainly, in the sense that, so whenever someone goes into cardiac arrest, primary or secondary, we treat the importance as the same. If there is an element of deterioration and we spot that the person is deteriorating, before going into that cardiac arrest, we would want to manage them and prevent them from going into cardiac arrest, if I've understood that question correctly.
I'm being asked if you could slow down again. It's all right, I'm getting the messages from my left. It's fine. And I'll try and remember to ask you from time to time as well. And just following on from that last answer then, is it important, would you say, that staff on an inpatient ward are properly trained to recognise when that emergency response, when that deterioration and that emergency response is required?
Absolutely. Whilst we teach people how to do resuscitation, the primary, most important element of this is to prevent people going into cardiac arrest, because you have a greater chance of survival for managing these individuals as they deteriorate rather than once they get into a state of cardiac arrest.
You had started to tell us about the kind of interventions that might be of assistance in these critical seconds and minutes. And I think you'd already started by saying removing the ligature. And of course, that would require easy access to ligature cutters.
Correct.
Come back to that in a moment.
Sorry, you may have answered this, but I was elsewhere. What is the... I mean, you may not... Every circumstance will be different, won't it? But the time scales you're dealing with in terms of finding someone who has, say, got asphyxia and is deteriorating and might go into cardiac arrest.
Yeah, it's
how long is a piece of string? But
exactly.
Can you give me some time frames that would help me?
It is literally a piece of string. It's very difficult. So for, as an example, an individual who has an asphyxial event, we roughly know that the oxygen blood saturations are, so there's the amount of oxygen within your blood, we look at it as a percentage between 0 and 100. We roughly know that when that drops, so normal levels between 94 and 98, when it drops to around 60%, the individual's likely going to lose consciousness. Yeah. And from that point on, within 10 minutes, they're likely to be dead.
That's so helpful, thank you.
So, and picking up from that, we've dealt with dealing with interventions. Another very, very important intervention is recognising and managing airway and compromised breathing.
Correct.
Dealing with those dropping oxygen
Correct.
levels. And in broad terms, what would that involve?
So again, depending on the situation, if you've got an unconscious person, their ability to protect their own airway gets compromised. So we would expect individuals to be able to do simple things which we call manual airway maneuvers, so using your hands to open the airway in a position where you can then easily ventilate. It might also be a case where we then look at putting what we call airway adjuncts into devices to help support and keep the airway open, very simple airway adjuncts. And that also might include taking over if someone's got an abnormal respiratory rate, a low breathing rate, that we might assist them to breathe before they actually go into cardiac arrest, so we can supplement their respiratory rate and give them oxygen.
And we'll, so giving them oxygen, and we'll look later at some of the equipment that can be used in order to provide that oxygen. But there are varying, as I say, there are varying levels and varying levels of ability and qualification or knowledge
Correct.
or training required. So as you become, there are certain aspects of providing that oxygen which would require certain levels of training, for example,
Correct.
immediate rather than basic.
Yes.
You also, at paragraph 12, refer to monitoring deteriorating vital signs. So how would that be done?
So we use the term vital signs. Historically, people might have used the term observations and OBS, and that's very much looking at someone's respiratory rate, so how often they're breathing a minute, looking at the oxygen saturation, so the percentage of oxygen within their blood, looking at their heart rate, so looking at their blood pressure, looking at their level of consciousness with that as well, and their body temperature. So these are what we call vital signs. And everyone, we have a normal range for adults and children, quite happily. And we look for when there's deterioration or changes within that, and that should lead to how we escalate and raise a concern for an individual. This is important, and it's been recognised and it's embedded throughout all of healthcare within the UK, the importance of monitoring vital signs and recognising when deterioration or changes happen, because it's well documented in the medical literature that actually you can get signs and symptoms of deterioration hours before something happens, if there's a physiological deterioration in that sense.
I'm being asked to ask you to slow down again, Mr. Benson-Clark. I'm sorry. You refer to the use of an early warning system.
Correct.
What sort of system are you referring to?
So in England, we have a national early warning scoring system.
The
News.
The news.
News 2. It was created by the Royal College of Physicians. It's used throughout England's healthcare organisations as a set standard. So there's no deviation, so clinicians are familiar with this tool. And what that does, it gives a scoring criteria for abnormality within your vital sign ranges. That then dictates, the score dictates where you take that, what the escalation plan will be. And that could be simply, if it's minor, to increase the frequency that you're observing your patient, or if you've got a greater level of concern, actually activating an emergency team to come and see your patient imminently.
But within our scenarios that you've been giving evidence about, you would have expected that emergency team to have been called from the outset anyway, is that right?
For stuff like asphyxia, which is very, very acute and quick, you're not going to pick that up in a form of doing a vital sign assessment. You'll see it not quite happily, but you'll see it very being evident. So you would call for expert help at that time.
Particularly as we've already established, and I appreciate it will depend on local variation, but it's unlikely in the majority, as you say, of mental health inpatient units that there is that specialist resuscitation team. There will be other arrangements. I think you would suggest those with advanced training, for example, you're nodding, is that right? Or a protocol by which the ambulance is called immediately and so on and so forth.
Correct, absolutely. But there's also elements where individuals within these facilities will have other physiological health needs. So it's still very important that they recognise when deterioration may happen, because you may get individuals who have severe asthma or other elements within their normal health journey, which aren't related to mental health, but they're in a mental health institution because of the requirements of their mental health.
So therefore emphasising the need to be aware of the other diagnoses. And the chair has already asked you this, but again, can you, just to get some sort of idea, speed is of the essence here?
Absolutely.
You've already explained that once a person goes into cardiac arrest, they may be dead within 10 minutes. Can I just ask you the kind of window opportunity, you may not be able to give us an answer, between trigger an event and cardiac arrest? I know you're treating it as if it were anyway. How much time do you have to prevent it?
So the scenario I very much gave was purely for asphyxiation, where
Yes.
we've got it documented based on animal studies. It is very difficult to give a time frame. The body has brilliant coping compensatory mechanisms to try and prevent deterioration, and it's when those coping mechanisms don't work or they get to the point where they can't cope anymore, that's when someone will collapse. But what we do know is for physiological health, sometimes these signs and symptoms can present for up to 12 to 24 hours beforehand.
Can I move then to ask you about the standards, the RCUK quality standards, with all those issues and clinical issues that you have just given evidence about very much in mind. In terms of the quality standards, RCUK first published those standards, the standards for cardiopulmonary resuscitation practice and training, in November 2013, is that right?
Correct.
And by way of background, prior to that time, RCUK had obviously already published resuscitation guidelines, and you've explained it.
Yes, clinical guidelines, correct.
And so the standards, in effect, they weren't new as such. They presented existing guideline-based principles, I think is how you describe it, as a single set of core standards applying across healthcare settings.
Correct. So it takes the clinical standards or the clinical guidelines And the quality standards then look at how can we manage healthcare organisations to reduce the risks and provide good governance to enable good quality or high quality resuscitation care to happen.
In terms of the documents themselves, there's an introduction and overview document. We'll look at
Correct.
that in a moment. And then they are divided into 7 separate setting-specific documents.
Correct.
And one of those sets out standards for mental health inpatient care.
Correct.
And there is a separate equipment and drugs list for mental health inpatient settings.
Correct.
Now, when those documents, the mental health inpatient related documents, were published in May 2014, was that the first time that formalised national standards had been published in respect of mental health inpatient care by RCUK?
That is correct.
Now, you refer to them, I think, for convenience within your statement, but it may be how they are always referred to as the quality standards. Is it MHIC that you say, or do you say MHIC?
So that was just an abbreviation for
your
the
statement.
For the statement.
All right.
Yes, the title is quite long.
It is. In terms of their formulation as a set of standards specifically for mental health inpatient settings, you explain, and for those who are following, this is paragraph 28 of your witness statement, that the quality standards overall were developed through a formal working group.
Correct.
And you confirm at your paragraph 31 that there was no separate working group for the standards for mental health inpatient care.
Correct. But we did have representation from the Royal College of Psychiatrists.
That's my next question. It included a Dr. Williams from the Royal College of Psychiatrists.
Correct.
And his name is on the documentation.
It is.
That's why I'm... You've been asked a little bit more about that, and you've explained at your paragraph 29 that you don't have a record confirming that any other named psychiatrist or psychologist or mental health nurse was a formal member of the working group.
No, we don't.
So is this a correct summary? Can we take from that that RCUK did not get input from any other psychiatrist, psychologist or mental health nurse?
Not for the initial writing group. However, it did go to consultation with organisations and public consultation.
I'm going to come back as well, because I think you say at your paragraph 30 that you got feedback from individuals associated with mental health provider organisations and resuscitation services supporting mental health settings.
Correct.
You also say, I'm trying to slow down as well, Mr. Benson-Clark, but you also say that the draft standards were circulated through relevant professional networks.
Correct.
Is that what you meant? And that may have included practitioners working in mental health environments.
Correct.
Can I ask you this, looking back now, do you consider, or does RCUK consider, that the involvement of the Royal College of Psychiatrists and the consultation provided sufficient relevant mental health input?
That is difficult to answer because I haven't seen the feedback which came from the consultation. So Dr. Williams would have represented the college, and as part of their role would be to gather the thoughts of clinicians within that college. The part of that membership of the group was also the CPRO, which was the Council of Professional Resuscitation Officers, which has now been disbanded. So that held within that group resuscitation officers and resuscitation practitioners across the country who would have had the opportunity to comment on the standards, and that would have included individuals who work within mental health facilities.
All right. There was also, just for completeness, a patient advisory group involved.
Correct.
But the background to those individuals isn't known.
Correct.
In terms of the standards themselves, again, just understanding how they come about, there's no fixed revision cycle, is that right?
That is correct.
We know that they were most recently updated in 2020.
Yes, correct.
And you've provided the original version to the inquiry. I think we'll focus today mostly on that 2020 version.
Sure.
But in terms of revisions, just to be clear about it, you explain, this is at your paragraph 39, that the principles revisions between 2014 and 2020, you say principally reflected revisions to references, terminology, supporting material, including alignment with contemporary escalation and early warning scoring practices, rather than any substantial changes.
Correct.
And in terms of how those revisions came about, you explained that there was a writing group, I think you said, not a working group, a writing group.
A writing group.
But the process for review didn't involve the same level of stakeholder involvement that the original.
Not to the original.
All right. You also say, and this is jumping ahead to your paragraph 57, that in broad terms, there was no substantive changes between the quality standards for mental health inpatient care published in May 2014 and the revised ones published in May 2014.
That is correct.
You say that the version retained the same overall structure and materially the same standards. I think you identify that there were some additional example measures in the appendix.
Correct.
And we know, and we'll come back to this a little later on in your evidence, that there were some additions to the equipment and drugs list.
Correct.
We will also come back to this towards the end of your evidence, but they're due for review again, aren't they, these standards? And that's in this calendar year.
Yes, so part of my strategic work plan this year was to always look at reviewing them, recognising that they haven't been reviewed for quite some time.
And as far as you're aware, as I said, we'll come back to this at the end, are they still on track to be reviewed by the end of this calendar year?
We haven't set a timeline to start them due to competing priorities, but I would like to get them done within this financial year.
Okay. Sorry, did you say financial year?
We work to a financial year.
Okay. Can we look then together at the current version of the standards? Now, what I'm going to do is I'm going to ask that some of them be put up on the screen, and it should, all being well, Mr. Benson-Clark, come up on the screen in front of you. But you do, I think, also have paper copies, so you've got both options if you like. So I'm just going to make sure it's your exhibit ABC2, which is the current introduction and overview.
Yes,
we need the URN for that, or you've got it? Oh, so we do. Thank you. And could we look, please, at the bottom of page 3 then, I think, all being well? And the part that we can actually see there at the bottom of that list, I think we saw Dr. Williams listed as part of the working group, but we'll start with introduction and scope. And just in terms then of the introduction and scope, they read as follows. Healthcare organisations have an obligation to provide a high-quality resuscitation service and to ensure that staff are trained and updated regularly and with appropriate frequency to a level of proficiency appropriate to each individual's expected role. And if we look down your list, we can see there at number 4, mental health inpatient care listed as one of the specific settings. But just before we leave that paragraph, do we see that the emphasis on training and update is to an individual's expected role?
Correct.
Now, the reason I ask that, and it might seem like a trite observation, but is the assumption here that the organisation must equip an individual to do what is required of them, as opposed necessarily to what their job title involves? Do you see what I mean by that?
I do. And essentially, it's similar to asking that a registered nurse takes on much more advanced skills that the doctor may sort of take traditionally. What we mean in this sort of indication is that organisations should undertake a localised risk assessment and training needs analysis based on their organisational structure, so that how do they then manage these events? And a great example of that would be if we look at ILS as a standardised course, that nurses should have this as a standard, but there might be elements where, because the interventions that are given, then actually healthcare assistants also have this level of qualification. And that nurses also may be trained in additional skills, or doctors specifically trained in additional skills to manage these airways because of what the organisational need is.
So we're going to come back to ILS and HCAs in a moment. But I think the answer to the question was yes, these standards contemplate that there may be circumstances where certain professionals are given additional skills because of what they need to do on a day-to-day basis. But you leave that to the local or the organisation to determine.
That's correct, yes.
All right. We can also see, sorry, can we go to the top of page 4, please? That's the next page. That one of the aims of the standards was, of course, to provide, we're looking at number 3 first, new standards for mental health inpatient care. And another one, up to number 2, was to update existing quality standards, but with a particular emphasis on simplification to improve implementation. So to make things easier for organisations to follow.
Yes, so whilst the quality standards are designed in some way to be aspirational for organisations, we don't want them to be a blocker from providing good quality resuscitation care. So therefore, within these documents, we give references and recommendations on how these can be implemented to enable individuals to achieve a level within these standards.
We'll come back to the question of aspirational in a moment when we look at the terminology, because you do try and distinguish what is aspirational and what is mandatory, if you like. My word, perhaps not yours, in relation to language. But before we do that, can we look at the core standards, which is at the bottom of page 4, going over to page 5, please? And these are the ones that apply across all settings.
Correct.
And if we look at them briefly, and I think then it'll be about time for a short break, but they pick up, we can already see on some of how they dovetail with some of the clinical scenarios and issues that you've explained to us. So the first core standard is that the deteriorating patient is recognised early.
Correct.
And we've already seen, you've already explained the importance of that, for example, in a mental health setting, and that there is an effective system to summon help in order to prevent cardiorespiratory arrest.
Indeed.
And then number 2, that cardiorespiratory arrest is recognised early.
Correct.
And that CPR is started immediately.
Correct.
And of course, we set this now against your evidence of the seconds and minutes and the short time frames. Number 3 is that emergency assistance is summoned immediately as soon as cardiorespiratory arrest is recognised, if it hasn't been done already.
Correct.
Number 4, if we could go to the top of the page, is defibrillation, if appropriate, is attempted within 3 minutes of identifying cardiorespiratory arrest. Now, just pausing there for a moment, you've already explained why it's often and usually important to use a defibrillator anyway. Mm-hmm. And that's a very short amount of time that you would expect defibrillation to be taking place within 3 minutes.
It is a very short period of time. But the reason being is within the clinical evidence is the quicker you get defibrillation in, and the marker that's used within the national and international literature is of 3 minutes, has the greatest chance of success of converting that rhythm into a normal rhythm.
Understood. Number 5 is kind of moving on to after appropriate post-cardiorespiratory arrest care is received by those who are resuscitated successfully, including safe transfer.
Correct.
Number 6, implementation of standards is measured continually and processes are in place to deal with any problems identified, so that there's monitoring of how effective they are. Number 7, staff receive at least annual training and updates in CPR based on their expected roles, and there's that expected role element again. 8, staff have an understanding of decisions relating to CPR, and appropriate equipment is available for resuscitation.
Correct.
I'm going to ask you a minute about terminology, but I think, Chair, I'm told that would be a convenient moment for a break, unless you have a question first.
Yes, I do. I have one, and I'm sorry if you think you've already answered this. You've talked about the need to defibrillate very quickly after cardiac arrest. You've talked about that hopefully buying you time to reverse the damage of whatever it was that caused the cardiac arrest. I'm not going to ask you this time how long you've got, and because it will depend, won't it, on whatever the circumstance was that caused the cardiac arrest. Mm-hmm. But suffice to say, it's a very short period of time.
It is.
What is the incidence of revival from that?
So,
from the event of cardiac arrest?
So we monitor this nationally with two arms. So looking at out-of-hospital cardiac arrests, which are in the community based at home, that survival from the cardiac arrest we call it survival to hospital discharge, because that's a good marker for someone's essential survival. That is around 9.5% currently. It's very low. Within an acute hospital setting, it's around 26%. We don't have data for mental health hospitals, unfortunately.
Thank you. That's helpful.
Thank you, Chair. It was 12:05, I'm told.
12:05.
Thank you.
Mr. Benson-Clark, before the break, I asked you about the survival rates from cardiac arrest, and you told me about them in all settings and then in acute hospital settings. Did that, those figures cover both primary and secondary cardiac arrest?
Yes.
Do we know what the same figures might be in relation simply to secondary cardiac arrest?
I don't have that information to hand off the top of my head, I'm afraid, but I can let you.
Is that available?
We'll be able to get that. I'll be able to get that information for you, yes.
And for today's purposes, could you just tell me whether that is a significantly poorer outcome?
Very much so.
Very much so.
Yes.
Thank you.
Thank you, Chair. Mr. Benson-Clark, can we return then to the standards and to the introduction and overview? And can we have a look at your exhibit ABC2 again and the top of page 6, please? And reference to, we refer to the terminology because you've given evidence that certain aspects of this, you recognise that certain aspects of the standards may be aspirational, to use your word. When we look through the standards, we notice the language that is explained here. And it says, in terms of terminology, the term must has been used when the consensus is that the standard promotes normal practice and is obligatory. So that would not be aspirational. Those would not be aspirational requirements. The term should has been used when the consensus is that the standard promotes normal practice. Again, not aspirational, would you agree?
I would hope not, yes.
The term recommends is used when the consensus is that the standard promotes best practice. So those might be aspirational aspects. All right, that can come down now, thank you. And instead, could we put up, please, your exhibit ABC5, which are the quality standards for mental health inpatient care. And look, I think, at the bottom of page 1, please. And it's the last paragraph. We won't need to look at the terminology again because it's the same, isn't it, within this documentation. But do we see this, looking at the Resuscitation Council UK recognises that the standards in this document, this is the quality standards for mental health inpatient care, may provide challenges for some mental health services and the organisations that are responsible for providing them. Intentionally, these standards are aspirational in certain areas, and you've just explained a bit about that. Where appropriate, each section contains links to implementation tools or examples of good practice. Each section also contains guidance on measures to assess adherence to standards. Off the back of your last answer, is the organisation, sorry, I was going to say how is an organisation to know which aspects are aspirational? Is that by reference to the terminology?
Yes, it should be referenced throughout the document. The terms should, must and recommend should appear within the standards as written.
Do you think your recognition that these may be aspirational might give an organisation some flexibility in not complying or not adhering to your standards?
I would hope not.
Why is it that you recognise, as set out here, that these standards provide challenges? What is it about them?
I guess the challenge element will be because they are mental health into hospitals institutions can be very different depending on where they are and how their setup is made. We mentioned earlier about if they're co-located, they might have pull from additional resources from acute trusts. Those which are standalone organisations may have more differing challenges because they may not have the same level of medical cover where they can pull from the acute hospital. It might then mean there's differences in training and elements and where they might be located. So as in a sense of their escalation is calling for an ambulance, and even in some of these co-located sites, they still might need to call an ambulance to get the patient to the acute part of a hospital. So we recognise that by nature of where some of these institutions are, there can be challenges.
So those are kind of geographical issues. Are there any other aspects of a mental health or features specific to a mental health inpatient unit that you might consider would provide challenges to implementing your standards?
The only other thing I can possibly think of in those sorts of senses is that we do know nationally that there's higher turnovers in staffing pools as well. So therefore, training elements can become quite challenging in those sorts of senses as well.
All right. Thank you. Can we have a look a little bit more then, and we'll go to part 1 or section 1, which is standards for service structure, and that's at the top of page 3, please. Don't worry, I'm not going to read them all out, but just pick up some key features. So, 1, we see that every healthcare organisation that admits mentally ill people must have an identified resuscitation service structure. And that at 2, every organisation must have an identified board member who is responsible for resuscitation services. And this was required in England by Health Services Circular 2000-028. And that dates us back to the year 2000, doesn't it? So this has been a governance requirement for some considerable time.
Very much so.
And it goes on, if we look at the bottom of point 2, to say that's to ensure that a resuscitation policy is agreed, implemented and regularly reviewed within the clinical governance framework.
Correct.
If we look then at 3, it says that the resuscitation service structure must be part of each responsible authority's management structure. So therefore, clinical governance, clinical risk, quality improvement, education service structures.
Correct.
And it says at 4, that it must include local resuscitation experts. Can I just ask you what is meant by or what is intended by local resuscitation experts?
So a local resuscitation expert could be either a resuscitation officer, so someone who has a clinical interest and skill in resuscitation practice.
Can I stop you? Because obviously the standards require every organisation to have one. Do you mean a separate one? Or just, can it be the same person within the...
It could be the same person.
Okay, sorry, I interrupted you.
No, that's fine. It can also be a doctor who has interest or training within resuscitation as well. So someone who is familiar with resuscitation, who's had training in advanced level resuscitation, is familiar with resuscitation governance.
Looking at 5, it says that the lead person responsible for the resuscitation service structure must have an active and credible involvement in resuscitation. What do you mean by credible involvement?
So that's quite a broad term, because actually what we don't want people doing is resuscitating everybody every day, that type of thing. So when we talk about someone who is credible in the field of resuscitation, so they will be individuals who are trained to a high level of advanced life support, to a standard where they are proficient in teaching that element, who have understanding and knowledge of resuscitation risk management and governance.
Moving to 7, the service structure is responsible for implementing operational policies governing CPR practice and training.
Correct.
And can we have a look at number 8, please? Because I think this would appear particularly relevant given the clinical evidence you have given. It says that in the absence of other organisational arrangements, the resuscitation service structure must also be responsible for implementing operational policies that govern prevention of cardiac arrest, including recognition of patients who are deteriorating before they arrest.
Correct.
So this recognises, again, this small window of opportunity and the need to act quickly.
Yes, and in some organisations, you may get a different governance group that look at prevention of deteriorating patients as a whole, and a separate element that look at cardiac arrest and resuscitation management. But what we very much say is if they don't have one looking at deteriorating patient, that must fall under the remit of the people who look at the resuscitation governance.
Would that be a best practice, an ideal world, to have a separate group of people looking at the prevention?
Not necessarily. It depends on the expertise you have in your organisation.
Okay. If we can move to the top, please, of page 4, rather than go through them. We see the responsibilities of the resuscitation service structure listed there, and I'm not going to read them all out, but just some key bullet points are ensuring the implementation and adherence to national resuscitation guidelines and standards.
Correct.
We also note, looking a little bit 1, 2, 3, 4, 5 down, planning adequate provision of training. It's particularly key, would you say?
Absolutely, yes.
I mean, they're all key, but training is a particular focus, I think. Determining requirements for and choice of resuscitation training equipment, and preparing and implementing policies, again, including those relating to prevention of cardiac arrest and recognising patients who are deteriorating.
Correct.
And of course, we have recording and reporting and quality improvement and such like. Interestingly, if we look down a little bit further at 13, it identifies that there must be defined financial support. So there have to be clear resources allocated.
Correct, yes.
Section 2 of the mental health inpatient care standards deals with resuscitation officers, which I just asked you about, and you explained that they may be part of the local expert contingent. And I just wondered if we could look at point 14, which is at page 6, I think. And I just wanted to ask you about this. It says, in order to maintain standards and clinical credibility, it is recommended that responding to and participating in cardiac arrest management is an integral part of the RO's clinical responsibility. What does that mean?
So for organisations which have a resuscitation officer on site who work within the hospital, if a cardiac arrest call should go out, it should be part of their expected role that they should attend.
So it's an on-the-ground experience requirement, a do, not just a say.
Essentially, yes.
A doer, all right.
Absolutely.
Do you have any position, as in RC UK, on who should supervise resuscitation officers? Who do you say should supervise them?
That's a tricky question. It depends on the environment. So, as an example, in an acute hospital, they will either come under education because of the level of training that they give to people. However, they are very much clinical specialists, so you often find them either under intensive care, as an escalation in that sort of sense. And sometimes they actually end up in corporate, which is an odd place for them to be. For mental health organisations, it's very difficult, depending on what their governance structure would be. They should sit under a clinical service predominantly, but you might find they also fall under education.
Can we look at part 3 or section 3, please? And I think that's the top of page 10. The title is cut off, it must be on the previous page, but this is training. Am I right, Mr. Benson-Clark?
Yes.
And I think
correct.
let's look at the standards here. So in terms of training, and particularly number 1, it says all healthcare staff must undergo resuscitation training at induction and at regular intervals thereafter to maintain knowledge and skills, and that training must be a level appropriate for the staff members' expected clinical responsibilities.
Correct.
And you've already given evidence around what you mean by expected and how that there can be contemplation of additional skills. In terms of whom these training standards or to whom they apply, you give some clarification in your witness statement about this. And for those who are following your witness statement, it's paragraph 60 of your second witness statement. And you say this: the terms healthcare staff, which we've seen in number 1, clinical staff, staff who care for patients in any mental health inpatient setting, and medical, nursing and other clinical staff are used to describe staff with patient-facing clinical care responsibilities.
Correct.
So that's who you are talking about as those terms are used variously within the standards.
And I recognise that in our document we've used those terms interchangeably.
You say these terms are not intended to create separate or mutually exclusive categories.
Correct.
Healthcare assistants may fall within these terms.
Correct.
Where their role includes patient-facing clinical care responsibilities or an expected response in a clinical emergency.
Correct.
The exception you explain is where the standards refer specifically, I've put the word specifically in, but you say refer to non-clinical staff, which you say specifically refers to staff without clinical care responsibilities, and you refer to administrative staff.
Correct.
Moving then to number 3, you say this training must include use of an early warning scoring system to identify deteriorating patients. You've already given some evidence about that, including a use of escalation protocol to ensure early and effective treatment of patients in order to prevent cardiac arrest. The scoring and escalation system must be the same as that used in actual clinical care, and use of the early warning score news is recommended. So there's an example of perhaps an aspirational or something that gives the organisation flexibility in any event. And it's echoed in point 4 below, which it's dealing with, and we'll come back to this in a little while, according to NICE Guideline 25 and NPSA Rapid Response Report, staff who care for patients in any mental health inpatient setting must have competencies in monitoring, measurement and interpretation of vital signs. They must have the knowledge which is appropriate to the level of the care they're providing. So again, it's in terms of what they're actually doing rather than their job role, to recognise patients' deteriorating health and respond effectively to acutely ill patients. At 5, there is reference to RC UK's immediate life support course, and it's got a very specific requirement. It's recommended as a minimum standard for staff who deliver or are involved in rapid tranquilization, physical restraint and seclusion. This guidance recommends that clinical staff in each mental health inpatient facility should receive regular update training in physical health skills in addition to ILS in response to an assessment of need undertaken by each organisation.
Correct.
And you gave some evidence earlier about the importance of being able to monitor physical health at the same time. And is that particularly important then in cases where restrictive interventions are used?
Absolutely.
And why is that?
So as an example, if we are giving tranquilization to a patient, we will give them a drug which could reduce their respiratory function, respiratory rate. So it's really important that every medication we give can have a consequence, that we're continually monitoring our patients to make sure they are safe and that we can intervene if need be.
Can I move on to 7? And it says this: according to Resuscitation Council UK guidelines, training must be in place to ensure that clinical staff can undertake CPR. Training and facilities must ensure that when cardiorespiratory arrest occurs, all clinical staff can, as a minimum, recognise cardiorespiratory arrest, summon help, start CPR, and attempt defibrillation, if appropriate, within 3 minutes of collapse using an automated external defibrillator or manual defibrillator.
Correct.
Can I ask you this? Well, firstly, all clinical staff would include any patient facing clinical care or response in an emergency, which would include a healthcare assistant.
Yes, correct.
That's first. In terms of defibrillators, you've already given some evidence about this. An automated external defibrillator, an AED, is one that gives, I think you already said in your evidence, it gives prompts. It tells you what to do, tells you to stop.
Correct.
Manual one is slightly more problematic. You help us if you can with this. Is there any particular guidance? Are you aware of what type would be on a mental health inpatient unit?
So predominantly they will be AEDs, the automated version. And that's because clinicians need to be competent and confident in rapid recognition of analysing heart rhythms. So within the guidelines, we say that you need to be able to correctly identify and diagnose that rhythm within 5 seconds, which is exceptionally quick. For majority of particularly nursing staff who don't necessarily work in a cardiac area or emergency department or higher level care area where they're used to looking at heart rhythms, you'll find that AEDs are the go-to device even in acute hospitals. And they can be used everywhere.
I was about to say, is that because of the level of training required or not required for
Absolutely.
an AED?
They are designed to be used with minimal to no training whatsoever. And that's why we see them in public places.
In terms of non-clinical staff, could we just drop down to 11, please? It says here that the expectation is that non-clinical staff have the resuscitation skills that would be expected from a layperson. As a minimum, non-clinical staff should be trained to recognise cardiorespiratory arrest, summon help, and start CPR using chest compressions. Now, having looked at what you said in your witness statement, do we take that to refer to, as you say, people without patient-facing responsibilities, such as admin
correct.
staff? So HCAs, healthcare assistants, would be in that first bracket?
They would be in the clinical element, absolutely.
So in terms of the assumptions that underpin all of this, can I ask you, is it right then that they work on this basis, that sometimes HCAs are regularly solely responsible for observing patients who are at risk of a clinical event that might cause cardiac arrest?
They certainly might be in some organisations, particularly if an individual is, in healthcare, we might use the term being specialed, so where they're being one-to-one monitored. So
level 3 or 4 observations, for example?
Possibly, yes.
And what, or somebody who is, for example, maybe a ligature risk or an overdose or...
Absolutely.
Okay. And are they drafted then, these standards, on the basis that HCAs are often responsible for checking vital signs?
In most healthcare organisations, that role of checking vital signs is often delegated to healthcare staff, healthcare assistant staff.
And they're often...
But not exclusively.
Sorry, I spoke over you. You may need to give that answer again.
But I said, but it's not exclusive in that sense.
No, but they may do it. It may be part of their role. They are often the first on the scene. Sorry, Chair, I interrupted you.
No, finish now.
They are often the first on the scene of an emergency.
They can be.
Yes.
You've talked about the training you would expect people to have in these circumstances. How long would a training course that covers the things you've recommended last? How long would that take?
As in the duration of a course or
Yes.
in between training?
The duration of
Duration
a
of the course.
course to get people to the standard that you would expect.
So I'll start with our ILS course because that's very easy to do within the programme. That's a full day training.
4 days.
Full day, one full day.
So that's ILS, did you
That's
say?
ILS. We have a set programme for that, which is a national standard. And that could be split up in between e-learning, which takes the theory away, and then half a day practical. But the length of time spent on that training is a day. For basic level life support, that's very much, it depends on the organisation and how they've set their training up. They would need to do hands-on skills for chest compressions, managing ventilation, and using an AED. But they might also add additional levels of training within that, sort of like recovery position, how to manage choking or other elements, what's the requirement to their role. But it can vary depending on what the organisation require.
But an average one to get somebody competent in basic level skills?
It's very variable between different organisations, and competence is a difficult thing in itself because that's measured over time. So what you're essentially doing when you provide training is make sure they can use the skills, they can recognise deterioration, and that's why we recommend that people have refresher training to make sure those skills get embedded. But it's very difficult for to say a programme because it really depends on the length of time that the organisation allow that individual to do.
But if I said I'm going to a course that's going to take half a day, you wouldn't consider that absurdly ambitious?
No, not at all. Some hospitals will do 4 hours, half a day. Some might even reduce it down to an hour and support that with online e-learning because there's a compromise that is often seen about taking frontline clinicians away from the workplace to do mandatory training. And I know that's being reviewed by NHS England at the moment, looking at the amount of time lost from providing direct clinical care. But actually, we have to weigh that up by essential skills that individuals need to so that they can provide good, robust quality care on the wards.
Can I just pick up on something the Chair just asked you? So when you were talking about courses that may be half a day, 4 hours, maybe even reduced to an hour, would that be basic life support training with some enhancements? For immediate, would you still consider that ought to be a longer and full day?
So yes, for basic life support. If they are using an RCUK ILS course, they are not allowed to change the programme.
Right.
They can add to it with bespoke training, but they can't reduce the content.
We'll come back to that in a moment, but you're not the only providers of ILS. That's right,
No,
isn't
there are. So whilst guidelines and standards from national bodies will recommend an ILS level course, they will benchmark that against our standards and what's in our course, but there's no remit for it to be an RCUK accredited and validated course.
All right. We'll come back to that in a moment, but I just wanted to pick up on that. And in fact, it's right. Can you help us with this? Is it right that the vast majority of providers, or a lot of providers, only require their doctors and their nurses to complete ILS training?
It very much can be the case, yes.
Okay. Just going back then to your standards, because we have a number of standards which apply to all staff, so that's clinical staff, administrators, that's everybody working. And we look, number 12 is that all staff must know how to summon help and be aware of the protocol for the settings in which they work. This could be dialing 999 or a standard telephone number within the organisation. We recommend that this should be a common national number, 2222, as recommended by the National Patient Safety Agency. And so to pick up there, it's as a must, everyone must know how to get help.
Within their organisation, yes.
And obviously it will vary from organisation to organisation, unit to unit and ward to ward. But everybody needs to be clear as to how to summon help in emergency. Absolutely. And what that might involve. Similarly, at 13, I think you refer to all staff again. You say a variety of methods to acquire, maintain and assess resuscitation skills and knowledge can be used for annual updates of all staff.
Correct. And
so you reference life support courses, simulation training, in-house training, mock drills, rolling refreshers, e-learning, video-based training, self-instruction, etc. But again, you are contemplating that this is all staff that are assessed and who must maintain their skills.
Correct.
14, there must be a system for identifying resuscitation equipment for which staff require special training. And there we have your defibrillators. Although I think you've said you need almost none for AEDs.
That's correct, yeah. It's more so about, we look at the training regarding defibrillators in a workplace, how do they change batteries and the insert pads and stuff, rather than the use of device. That's for specialist training.
All right, that's helpful. And at 15, all new members of staff must have training resuscitation as part of their induction programs. Even those who have current training require resuscitation training on induction to ensure that they're familiar with the local policies and equipment.
Correct.
because they do vary from ward to ward and unit to unit, as you've explained.
Hopefully not from ward to ward, but certainly different organisations will buy in different equipment. So one hospital, Hospital A, may have a very different AED or some devices to Hospital B, and it's about familiarisation with equipment, what it looks like, but certainly also the policies are really important to be aware of.
Where it is, I suppose, is another one.
Well, where the location of equipment is, but how do we, particularly when you think about if part of your response in your hospital is, are you a 999 hospital? Do you actually have a co-located site? So what is your avenues? And all of these bits are guided by those local policies.
At 18, there's very specific. It's a specific training for cardiorespiratory arrests in special circumstances, and you give examples, for children of all ages who have collapsed, patients who are secluded or subject to restraint, and patients who have suffered blood loss must be provided for medical, nursing and other clinical staff in the relevant specialties. And at paragraph 62 of your witness statement, you say this: the same role-based approach applies to Standard 18, where healthcare assistants are expected to be involved in responding to special circumstances. They should receive training appropriate to responding to those special circumstances in the same way.
Correct.
Now, we'll come to some special circumstances in a moment because there are some examples here, but the significance here is that it's for anybody that might need to be involved, which would include healthcare assistants.
Absolutely.
And at 19, which I think is at the top of page 11, again, another all clinical staff, must receive training in recognising, monitoring and managing patients whose conditions are deteriorating.
Correct.
So if that's part of an HCA's role, they must receive that training.
Absolutely.
In fact, at paragraph 63 of your witness statement, for those who are following it, you say RC UK would expect healthcare assistants working on mental health inpatient wards to receive training in recognising, monitoring and escalating concerns about deteriorating patients appropriate to their responsibilities.
Absolutely.
We'll come on to training again in a moment, but are some of those skills then beyond what might be learnt in basic life support training?
You often find that basic life support training looks at what we class as technical skills. So recognising that a cardiac arrest has happened, summoning for help, doing chest compressions or performing chest compressions, providing ventilatory breaths and use of an AED. Where we look at deterioration, that's often excluded from basic life support training.
So
it's
it's
usually excluded.
So in order to obtain the necessary skills in identifying deterioration, an individual needs to go on an ILS course.
Well, there are other courses which are available to look at deteriorating patients, set at different levels. So it might be a case where organisations will utilise one of those courses rather than necessarily an ILS course. But this should be determined by their training needs analysis.
So whilst candidly accepting there are other ways to meet those needs, is a safe way to meet those needs for an individual to go on an ILS course?
I would certainly say so.
Yes. There's considerable emphasis in your witness statement and in your evidence about the early recognition of deterioration and the immediate recognition of cardiorespiratory arrest. Does RC UK provide detailed guidance on learning or training regarding the specific factors that should or should not inform early recognition of cardiac arrest?
So we include that within our immediate level courses and advanced level courses. So it's certainly part of our course curriculum.
So it's part of your course but not part of any guidance or the standards. That's something that you'd have to be on an RC UK and ILS course to access.
For one of our products, certainly, but there are other resources and standards out there. The most common one, which has a training package associated with it, would be from the Royal College of Physicians in association with their News 2 programme or score. So that tells you about the importance and how to recognise elements within, and that's quite a generic programme.
Okay. Can I then just ask you a little bit further about RC UK's position on who should get what training? looked at point 5 in the training standards, which is that RCUK's immediate life support course is recommended as a minimum standard for staff who deliver or are involved in rapid tranquilization, physical restraint and seclusion. You've already dealt with that, and you've already helped us that there are, in essence, 3 levels of training: the basic life support, the immediate life support, and advanced life support training. It comes in different guises, and we won't need to go into that. You have also given evidence that immediate life support is more comprehensive than your basic life support training, which I think is something someone like me could do. But in broad terms, and we've looked at some features, what other skills or knowledge does ILS training provide that BLS training does not provide?
So from a standard outset, the ILS training will go through in more detail recognition and prevention of cardiac arrest using a structured assessment tool called the ABCDE approach. And basically it looks at how you assess an airway, someone's breathing, their circulation. We class D as disability, and that's looking at their neurological function. And then E is exposure, everything else around the patient. And that's a structured system that's used internationally for assessment of a deteriorating patient. The course also goes into a bit more on how to manage an airway and recognise there's airway problems. So that might also include that when a patient has a cardiac arrest, that they could put in a supportive airway device like a supraglottic airway, sort of like an eye gel or something, and that basically protects the airway and allows ventilation to be delivered much more effectively and easier. The course also covers chest compressions, it covers defibrillation, either using an AED or if you need to use a manual defib, you can use that. But what the key thing about the ILS course is it introduces the concept of leadership and those non-technical skills, because you're managing quite a few people in your local environment. And what that does, it enables a structure to be delivered whilst you are managing that event, waiting for an advanced team to come and help, either be it a hospital-based resuscitation team with more advanced skills or a paramedic crew. So it really enables that facilitation of utilising the cardiac arrest algorithms and putting in place to make sure care is very much effectively given.
In terms of the RCUK's ILS training, can we just have a look at the regulations around that? And that's your exhibit ABC 8 at page 1. We see, and you've just given us if you like, a synopsis of what the course includes, including the ABCD approach, but its objectives are, this is the ILS, to train healthcare personnel in causes and prevention of cardiopulmonary arrest. The APCD approach, as you've said, initial resuscitation and defibrillation, manual and/or AED, and simple airway management. To train healthcare personnel to manage patients in cardiopulmonary arrest until the arrival of the resuscitation team, and to train healthcare personnel to participate as members of the resuscitation team.
Correct.
Is it that last point then that would include those elements of leadership?
So the leadership element would come into that second point until that arrival of the team.
The management part.
The management. But what we wouldn't want is for those individuals to, as the advanced team arrives, sometimes what you see happening in clinical environments is ward members and staff might then go away and leave the cardiac arrest management to the advanced team. Whereas actually there's no reason why they shouldn't stay and be part of that team approach and managing that patient altogether.
And in light of your previous answers, there's no reason, is there, that healthcare personnel shouldn't include healthcare assistants?
Absolutely no reason at all.
And can I just ask you this? Do you need any additional clinical qualifications or anatomical learning in order to take an ILS course? Could I take an ILS course?
So the way that ILS is delivered, we would expect people to have a bit of knowledge of physical health, but that comes in the form of the course manual. The course is open to any healthcare professional. It's also open to members of the public who might need it for their role. So we get firefighters on the course, we get police officers, prison guards, we've even had air stewards on the course as well, because it gives people the skill to manage that event in those circumstances whilst they're waiting for more expert help to arrive.
And I'm not going to ask us to jump to it, but healthcare assistants, I think, are listed in that list of
There's
of
absolutely no
appropriate
reason why a
candidates.
healthcare assistant could not do an ILS course. And in many acute hospitals, they do.
For completeness, because this inquiry has heard a lot of evidence about the care and treatment provided to children, and we're looking very carefully at the provision of mental health care for children, can we just confirm the position in relation to the paediatric ILS regulations? And I think that is your exhibit ABC 10, page 1. These regulations actually are a little earlier, aren't they? They're 2019, and I should have said that it's 2021 for the ILS, but they say they predate, but that the objectives effectively mirror, but with obviously some modification for paediatrics. So it's to understand the structured ABCDE approach that you've given evidence about that facilitates rapid recognition of seriously ill children, provide appropriate initial treatment interventions to prevent cardiorespiratory arrest, treat children in respiratory or cardiorespiratory arrest until the arrival of a resuscitation team or more experienced assistants, and become members of a paediatric resuscitation team. So with emphasis again on prevention, we can see that if we look again, it says that the paediatric ILS course will address the needs of those personnel who need more advanced skills than those taught during basic life support, but who do not require the more comprehensive 2-day European Paediatric Advanced Life Support, the EPALS course.
That's correct.
And can you confirm, we don't necessarily need to go to it, that healthcare assistants also appear in the appropriate candidate list for this as well?
Absolutely.
You pick up this at paragraph 107, in fact, of your witness statement, where you say ILS was developed for healthcare professionals who may have to act as the first responder in an emergency. Its purpose is to give individuals the skills to recognise deterioration, identify cardiac arrest, start immediate resuscitation, use defibrillation where appropriate, summon expert help, and manage the patient until a cardiac arrest team, ambulance clinicians, or other advanced responders arrive.
Correct.
And so the term first responder is the first person to arrive at the scene of an emergency.
Yes, in this setting, yes.
And just again, following on from that, this inquiry has heard evidence from bereaved families and from staff who work on mental health inpatient units that because of the way units are staffed, and you've already talked about recognising some of the challenges around staffing in mental health inpatient units, and because of the way observations are sometimes carried out by HCAs, and you've already acknowledged that they are sometimes delegated to HCAs, a healthcare assistant will often be the first at the scene of an emergency. And whilst we know that your evidence in your witness statement is that RCUK don't expect all healthcare assistants working on mental health wards to have immediate life support training as a blanket requirement, you do say that healthcare assistants can access ILS training where this is needed and appropriate for their specific role and organisation.
Correct.
Would you agree then that if HCAs are going to be first responders, they must be ILS trained?
Very much depends on, again, that environment and the level of support they've got around them. So if they're truly on their own in an area and they're expected to be involved in, say, like the rapid tranquilization, then they should have the skills to support the level of care that's required of them. If it's generic support, it might just be basic life support and recognition that they need in that sort of instance. You will find that in a lot of training that if individuals are taking vital signs, they should have training to say what is normal, what is not normal, and escalating that to a registered healthcare professional who can then take that information and act accordingly. That would definitely be a baseline standard. But in some areas you will find that there are healthcare assistants may only be trained in basic level life support because they have a supportive structure with mental health nurses around where they can words have lost me. Escalate, where they can escalate their concerns in a very timely manner.
So they would, so basic life support training would be sufficient if they had access to more qualified staff.
Exactly.
And were supported by those staff.
Exactly.
However, what if a person had to remain on their own with a patient whilst awaiting for the crash team or ambulance response?
If the individual is that sick where they've put out an escalation call for more appropriate help, then I would expect a registered healthcare professional to be with that patient.
What if staffing issues meant that it was an HCA? Should it be an HCA with ILS training?
An ILS trained HCA could support that, but realistically that should be a registered healthcare professional.
Can I ask you this? If it were to be recognised by an organisation that HCAs are often first on the scene, they might be required to stay with a patient whilst awaiting the ambulance or the crash team. Should they be ILS trained if the organisation knows that's going to be the position?
If there's an expectation to, then...
Sorry, better word than mine for sure.
That's right. If there's an expectation that that's what the organisation is saying should happen, then yes, they should have the appropriate level of training to manage that situation.
And would
that would be an ILS type level qualification.
As a minimum standard?
As a minimum standard. But ultimately and realistically, there should be, in that situation, a registered healthcare professional with that patient.
Can I flip it on its head, if I may? If those circumstances were to arise and an HCA who was not trained in ILS, is it safe then for patients who are at immediate risk of ligature or airway obstruction to be solely observed by non-registered staff that are not ILS trained?
Again, that would very much relate to if they've got appropriate help immediately available, so a ward with registered healthcare professionals on, that might be appropriate. If there's a reduced level, then they absolutely need some form of a way to manage that patient, recognise what's going on and escalate so that we don't miss the deterioration and the risk that happens. So ILS would be appropriate in that situation.
So if you're likely to have a situation with reduced staff levels, then that increases the need for a high level of training within the staff.
Because we need to reduce the risk of the clinical risk within that area.
Can I ask you a slightly separate question? Do you, RC UK, have a position on the minimum frequency for monitoring vital signs in mental health inpatient settings?
So we would follow the recommendations that are part of News 2, which has it sort of listed out within the escalation protocol within there that tells you how often you should be doing more frequent observations.
Does RC UK have a position on the use of Oxyvision?
It's not a company I've heard of or brand, but we wouldn't have a position on a specific brand or product on the market.
I think you know what Oxyvision is.
Haven't got a clue. Sorry.
I shan't ask you any more about Oxyvision specifically then. Can I ask about local need? One staff witness has given evidence that he considers, and this is from one of the providers the inquiry is concerned about, that he considers HCAs should receive ILS training in the same way as nurses because he describes how HCAs will often be the first on the scene, or they might need to get things out of the grab bag, but they don't know what stuff is in the bag. Now, would you agree with that staff witness assessment?
If they're first on scene and needed to respond, absolutely. For recognition of equipment, that's slightly different because that's equipment recognition. And you'll see that if they've got an advanced resuscitation trolley, which might have an intubation kit, you have a very limited set number of clinicians who can truly intubate during a cardiac arrest. So people need to be familiar what the equipment looks like, what it's called, to help with that process of that clinical task.
I've asked you a lot of questions around who should get it, who shouldn't get it. You've dealt with local need and you've dealt with scenarios. Do you consider there would be any merit in updating the quality standards so that there's greater clarity on who you expect to receive ILS training?
we can certainly put elements within that as guidance. It would ultimately be down to a local risk assessment and training needs analysis, because as I say, not every hospital is set up the same, but certainly we can put lines in there guiding people towards, if they are undertaking certain roles or have a certain level of responsibility, then they should have a minimum requirement of X, Y, and Z level of training.
I'm told that we're due a break in a minute, but before we have a break, can I ask you about a separate aspect of the standards, and this is section 4, which is preventing cardiorespiratory arrest, and it's at page 13 of your exhibit, ABC 5. And I can deal with this very quickly because I think it is the same point. But point 2, again, the RCUK's position that is an organisation must have an education programme for ward staff and responding clinical personnel that is focused on preventing patients' deterioration. And again, you pick this up in your witness statement at paragraph 65, where you say this may include registered nurses, healthcare assistants, and other patient-facing staff. It's the same point throughout, isn't it, about what that person is expected to do and the role they're expected to take. Whilst we're on this part, do we note, again, the re-emphasis at 4, that an early warning scoring system must be in place to identify patients who are critically ill and therefore at risk of cardiorespiratory arrest. And there is an example where the NEWS or paediatric early warning score is recommended.
Correct.
Where staff are conducting routine observations, would you expect them to be specifically trained beyond the use of NEWS 2 in recognising signs of physical deterioration?
So NEWS 2 is quite comprehensive. If you are a healthcare assistant undertaking observations and vital signs, I would expect them to be able to calculate the NEWS score and report that appropriately to the registered healthcare professional on the unit.
Can I ask you to have a look at 6? Again, this is a must. Organisation must have a clear, universally known and understood, mandated, unambiguous, graded activation protocol for escalating, monitoring or summoning responses to a deteriorating patient, and its use should be standardised. I think that's very emphatic.
Absolutely, and that is NEWS in a nutshell.
And 8, when acute clinical crises are identified, a 999 ambulance must be called if there's no designated resuscitation team, outreach service, or rapid response team that is immediately available.
Correct.
And at 9, the organisation must have a clear and specific policy that requires a clinical response to calling criteria or early warning systems, track and trigger. This must include the specific responsibilities of on-site, on-call doctors and nursing staff, and include when to call for the ambulance service.
Correct.
I'm going to move on shortly to asking you about responding personnel, but Chair, I'm told that we are due a break, and I'm asked if we can now return at 1:50.
1:50. Thank you.